hopefully I can just introduce some perspectives on more advanced aspects of renal imaging in the setting of chronic kidney disease. So as Kai said, my name's Nick Selby. I'm a professor of nephrology at the University of Nottingham and a consultant nephrologist at the Royal Derby Hospital. These are my disclosures, and there's nothing relevant to today's talk apart from some of the grant funding. So I think it's easy to make a case for why we need better imaging modalities in nephrology, and that's particularly true when you compare our specialty to other general internal medicine specialties where more advanced imaging is translated and is now used routinely in the management of patients. Compare that to nephrology, where the majority of patients with acute and chronic forms of kidney disease are still assessed only with the standard B-mode ultrasound. And in many cases, that doesn't contribute huge amounts to clinical decision-making. In addition, when you look at our sort of gold standard for looking at tissue architecture, the renal biopsy, we know that many patients with CKD don't have a renal biopsy, and in many cohorts, as shown here in the German CKD cohort, there's a large proportion of patients in whom etiology of their CKD remains unclear. So these are the two questions pertaining to imaging that we're going to try and address at this conference. Can innovative renal imaging enhance the quality of patient care in CKD? And then the second part of that, what additional information do we need to have to utilize these imaging techniques? And just for the purpose of this talk, I think it's worthwhile stating that question encompasses a number of different imaging modalities, but I'm going to focus just on MRI as an introduction. And you could argue that this is the area that has the most potential. It's certainly the area that's seeing most sort of research activity. And also, I think it's worth acknowledging that patients with CKD may benefit from multi-organ imaging, particularly cardiovascular or brain imaging, but the remit of these questions is to focus just on imaging the kidney. So in addition to the fact that CKD is a syndrome and improving our ways of diagnosing etiology is important, I think the other key area for imaging is in the assessment or monitoring or even prediction of CKD progression. And bearing in mind there are many people in this room who know much more about this than me, I think it's worthwhile just briefly mentioning the histological patterns of CKD progression, so then we can contrast that against the imaging techniques that we now have. So as you all know, the hallmark and the end stage of CKD progression is fibrosis, which is defined as deposition of extracellular matrix. But there are different elements to that. So fibrosis can happen in the vascular, the glomerular, or the tubulointerstitial compartments. It links inflammation to the fibroproliferative aspects of fibrosis, as well as the deposition of matrix and then the fibrocontractive elements of that. And in tandem, we see a loss of nephrons, a loss of capillaries, and a vasculopathy, and hypoxia is postulated as a key mechanism of progression. So against that, we've seen a number of developments in the last few years, and there are now MRI techniques that you can see might map directly to a number of those different processes. So MR can assess different aspects of kidney structure and function, blood flow and oxygenation that might provide really important mechanistic insights into CKD. Importantly, these different measures can be combined within a single 1-hour scan session, and none of the approaches that I'm going to talk about today involve contrast, so all are gadolinium-free. And I think it might be worthwhile just quickly talking through some of these different measures. So we know that MRI is the gold standard for measuring kidney volume, and it can also quantify cortical volume. That may have relevance to CKD progression, and it's also of particular interest in specific situations such as polycystic kidney disease, where kidney volume is now accepted by the FDA as an enrichment biomarker for clinical trials. Thinking about blood flow and hemodynamics, arterial spin labeling is a very elegant technique. It's a subtraction technique, but instead of using contrast, it uses magnetically labeled blood as the contrast to directly measure cortical perfusion. And in tandem, MR can also measure renal artery blood flow. So phase contrast MRI exploits the phase shift of moving water molecules in a blood vessel. And then renal artery blood flow can then be indexed to kidney volume to give a global measure of organ blood flow. Some MR measures are also sensitive to changes in tissue oxygenation. So BOLD MRI is well known in this regard. And BOLD exploits the paramagnetic effects of deoxyhemoglobin, which then affects the MR parameter at T2 star. However, a number of different physiological and technical considerations can affect the T2 star value, and that may explain some of the conflicting results that we see around BOLD MR in the literature. Newer techniques such as TRUST may help that. And then there are MR measures that might inform about the tissue microstructure. So T1 and T2 are tissue-specific relaxation times that can be mapped on a voxel by voxel basis across the whole organ. T1 is increased when water content of the tissue increases. So fibrosis causes an increase in T1 relaxation because there's extra water bound to the proteoglycans in the extracellular matrix. But T1 also increases with tissue edema and inflammation. T2 may be a bit more specific to acute changes, acute edema. That's certainly what you see in cardiac imaging. We need to know a little bit more about T2 in the kidney. And then the final sort of measure that I want to mention in terms of microstructure is diffusion MRI. So diffusion MRI tries to quantify the Brownian motion of water molecules in a volume of tissue. And it does that because then pathological processes can restrict that motion. So fibrosis restricts the movement of water molecules. And diffusion imaging quantifies that restriction in a variable called the apparent diffusion coefficient, or ADC. IVIM is then an advancement of that tries to separate out true diffusion of water molecules from water molecules that might be moving in capillaries or tubules, so highly relevant in the kidney. And then diffusion tensor imaging applies an additional directionality to the assessment, and that's the technique that produces these beautiful tractography images in the brain. There are other measures, elastography, multinuclear imaging, but we're not going to sort of get into those today. Importantly, the repeatability of these measures in both healthy volunteers and in CKD has now been reported. These are just data from two studies from our group, but you can see straight away that the measures, particularly pertaining to kidney volume, microstructure, and also the T2 star or R2 star values have very low coefficients of variance. So this gives confidence that actually MR will be able to track and detect quite small changes in individuals over time. And these data are also then important for clinical studies and sample size calculations and things. So what do we know from the current evidence base? Well, I think there are a rapidly expanding number of studies that compare these MR measures against clinical and increasingly histological correlates. So this is just one example from a Swiss group focusing on the diffusion variables, the ADC, and they report the difference between cortex and medulla, so delta ADC. And here they assess it in a reasonably large cohort of 164 patients, but it's a mixed group of CKD and transplant. And they show that this MR measure can differentiate patients with low and high fibrosis scores on kidney biopsy well. And they also then generate a predictive model to categorize patients into 4 different groups of fibrosis. And the observed versus predicted values are shown in the bar chart on that slide. The same group have also performed the only study that I'm aware of in which there's been repeat imaging and repeat biopsy. For obvious reasons, this is a small number of patients, and it's in transplant patients. But I think the results are interesting. So again, they're looking at delta ADC as the MR measure. And over time, they see an increase in the fibrosis score on kidney biopsy. And that's matched with a decline in the delta ADC value. So those two changes correlate. And that occurred in the setting when there was no detectable change in EGFR. So there's a hint here that progression of fibrosis is detected by MR, but it's not detectable with our currently available clinical tools. And then just this year, the same group, again in a mixed population of CKD and transplant, report the performance of delta ADC as a prognostic biomarker. So at delta ADC at baseline, it was able to discriminate those at higher risk of either a 30% decline in EGFR or progression to end stage. And the MR measure remained independently associated with that outcome even after adjustment for EGFR and proteinuria. Another Swiss group has looked at bold MRI at baseline and subsequent prediction of CKD progression. They use a specialized 12-layer analysis technique that you can see depicted in the image there. And again, there was a positive results. The patients with higher R2 star values, which suggests greater degrees of tissue hypoxia, that correlated with a steeper slope of EGFR decline and a higher rate of adverse kidney events. And I think it's important just to sort of acknowledge that these prognostic studies and imaging, I don't think we should be thinking about this as competition for albuminuria or KFRE for a number of very obvious reasons. But these studies are important because what they do is that they're now starting to link the quite large amount of cross-sectional data. Actually, those MR measures are now being linked with progression and subsequent progression over time, which I think is important as we build the evidence base. More recently, however, I think there's been a definite switch from moving away from single MR measures to actually a more comprehensive assessment of the kidney. So multiparametric MR, which combines a number of different MR measures within a single scan. And this is just an example from our group in which we applied multiparametric MR in a well-characterized group of CKD who'd also had biopsy and measured EGFR. We also had 22 age and gender matched volunteers, and it was clear that most of the MR measures, apart from bold actually, were able to differentiate healthy and CKD kidneys. And there were some interesting comparisons in terms of which MR measures correlated with each other and which did not, and the same differential associations between MR measures and clinical variables. And then 3 of the MR measures were able to distinguish low and high fibrosis scores on kidney biopsy. So it's not possible to review all of the recent publications. Some of those are shown here. This really is a rapidly expanding area, but to try and summarize where we are now, I think we can say that a number of these different MR measures can clearly differentiate healthy from diseased kidneys, and the MR measures also correlate with our current clinical variables of CKD severity, and we're seeing in particular measures correlating with EGFR slope, for example. The cross-sectional data comparing MR measures to fibrosis scores on biopsy is expanding, and possibly we can differentiate different thresholds. And we're starting to see now prospective studies relating MR measures to longer-term outcomes, although currently the published data are still only single-center studies. So that still leaves some unanswered questions, and these are hopefully the questions that we will be debating at this meeting. But I think it's also important to say that we've been discussing some of these questions for a little while. Just shown here is a consensus statement that came out from the parenchyma MRI research network a few years ago. And really that's there to just sort of show that this isn't a totally new concept. Work is currently going on to try and answer some of the questions that are listed here. And so I'd just like to give a very quick whistle-stop tour of some of the important studies that are currently in play. So I think to answer questions about MR measures, their relationship to CKD progression, how quickly the MR measures change over time and their relationship to albuminuria and that type of thing, we need prospective studies. They need to be multi-center, and ideally they need to contain repeat imaging over time. And to that end, we designed the AFFIRM study, which is a UK-based, but it's a multi-center prospective cohort study that's recruiting 450 patients with CKD. We've currently recruited about a third of those patients within the last 12 months or so. Patients are going to have a comprehensive multiparametric protocol at baseline. It will then be repeated after 2 years, as shown here. There'll be biosample collection, a subgroup in whom histology can be compared against MR measures, and then annual follow-up until year 4 with long-term tracking of kidney outcomes out to year 10. And in terms of the analysis plan, we're trying to move beyond simple associations and sort of linear regression, and we want to try and look at causal inference analysis to try and link sort of mechanisms to MR measures to then clinical parameters and CKD progression. IBEAT is also a large prospective multi-center study that's currently hopefully coming towards the end of recruitment. It's part of the larger BEAT DKD platform, and IBEAT will recruit 550 participants, this time with diabetic kidney disease. They'll be scanned at baseline, a number of other different assessments, and then 100 patients will undergo repeat scanning within the 3-year follow-up period. We're seeing now trials that are incorporating MRI as sub-studies. So the EMPA kidney trial has an MRI sub-study led by Richard Haynes and Parminder Judge, but incorporating investigators from Oxford, Nottingham, Edinburgh and Würzburg. And to date, 160 patients who've been randomized have been scanned on drug, and there's a potential for another 80 patients who've already been consented to have this done. And there are now also examples of clinical trials that have adopted MRI measures as endpoints. So the top CKD trial from the States is randomizing patients to pirfenidone as an antifibrotic agent or placebo. And their endpoint, or one of their endpoints, is the change in ADC, so diffusion measure, to try and assess renal fibrosis over a 12-month period. So I think it's important to sort of come back to the sort of the questions that were being asked at this meeting. And it's not about how good is imaging, it's about how imaging can change patient care. And so it's really important not to forget about some of the technical and the logistic considerations here. And this can only be resolved really by joint working between MR physicists, nephrologists, radiologists, and importantly, industry partners, so scanner manufacturers, for example, because there's a huge amount of work, as summarized on this slide, that's needed to standardize different imaging measures, particularly when we're talking about quantitative measures. So this is work led by Sue Francis in the UK, but it's harmonizing the different MR measures across different sites, and importantly, across the 3 major scanner manufacturers, Philips, GE, and Siemens. So if you take an MR in one place, you know you're going to have the same results from a different MR scanner at a different place. It involves quality assurance, so you can see some of the phantoms there that are used for that, and it's also developing an analysis pipeline. And research networks such as in the UK and Parenchyma that I mentioned previously have produced consensus recommendations. So everybody now should be working to these consensus recommendations in the way that they are acquiring these different MR measures. And for quantitative data, sometimes imaging, it's the analysis that can be labor-intensive and therefore sometimes costly. And again, this is an area where we're seeing progress, particularly with machine learning techniques, as shown here, that can be used to segment the kidney automatically and also then segment the cortex. And then upon that, the maps of the different MR measures can then be applied. So it automates or semi-automates the process and allows a much quicker analysis. So I'll finish there. I hope that this has been a useful introduction to some of the discussion that will follow around imaging. I have focused on MRI, but clearly want to acknowledge that the discussion is not just limited to MRI. It needs to include all imaging modalities. And then my final slide is just some acknowledgements, particularly to Sue Francis and her team, who lead the MR physics group at the University of Nottingham, my clinical team, and in particular my colleague and collaborator Martin Thal, who many of you know, and then the wider teams in the UK contributing to the technical work, and then everybody who's working on the AFFIRM study. Thank you very much for your attention.